Now we come to intraoral periapical techniques. The basic intraoral periapical technique, long cone parallel technique, noise, short cone bisecting angle technique. The long cone, like I told you, the film is held in a film holder and the film is positioned parallel to the long axis of the tube, of the tooth, and the central ray is directed exactly at 90 degrees. Okay, so this is known as long cone or paralleling technique. In bisecting angle technique, what happens is the film is held by the patient or a finger. You can also use a holder, but that is very uncomfortable. And there's the long axis of the tooth and the long axis of film, there is a bisector, and the central ray is directed perpendicular to this bisector to get a proper image. Now, though a long cone technique follows all the rules of projection geometry, we still use bisecting technique regularly everywhere. Can you think of why that is possible? Why do we do that? The thing is that the long cone, is very long. It's 16 inches. And that is too large a space. We need a lot of space, and we over here have a lot of space constraint, and therefore this is more comfortable to use. So let's compare intraoral periapical techniques, the short cone and the long cone. Short cone, diffusion and distortion of the image occurs. Long cone, you get sharp details. Short cone, increased chances of elongation and short. Long cone, image is obtained in the same size and shape as the object. Short cone, you have distorted image of teeth due to oblique exposure and bending of film. Long cone, image of the teeth nearly anatomically accurate. Short cone, shadow of the alveolar bone may be seen. Alveolar crest is seen in the true relation to the teeth. In short cone, increased vertical angulation, whereas in long cone, less vertical angulation. And because of this, the buccal and lingual parts of the teeth are close to each other on the radiograph, and more tooth area under the restoration can be seen. In short cone, superimposition of the shadow of the zygomatic arch is often occurs, so you are unable to see the periapical region, especially in the upper first molar region. This does not occur in long cone technique. Short cone, easier technique to maneuver, requires less space. Long cone needs a larger working space. Short cone, more effective when the palate is shallow, especially children with adult-sized teeth but underdeveloped jaws. Long cone, in a similar situation, apices of the teeth will get cut off. In short cone, in rare cases, when the teeth are longer than the film, the entire tooth may be seen by over-angulating the vertical angulation. But this is not possible in the long cone technique. In short cone, cone cutting is a common error. This does not happen in long cone because the PID is also has a positioning. The film holder holds the film and it has a PID positioning apparatus also. So the alignment becomes automatic. Short cone, curved film due to incorrect finger pressure. Long cone, use a film holding device prevents such an error. Now, this is the intraoral periapical radiograph which you see. When do we take intraoral periapical? Over here, these are all the ones on the periphery are intraoral periapical radiographs. The middle four radiographs are the Bitewing radiographs, which we will be talking about later. Indications of periapical radiographs is detection of apical infection, assessment of periodontal status, stroma to teeth, assessment of presence and position of unerupted teeth, tooth morphology, endodontic treatment, pre-operative assessment and post-operative appraisal of apical surgery, detailed evaluation of apical cysts, and assessment and position and prognosis of implants. Now we come. Now, before I go further, I want to be very specific about this because in your MCQs also, in your short SAQs, they ask you what are the contents of an X-ray packet. And there's another question which comes, describe the contents of an X-ray film. X-ray film is this small little green thing which is here. It has a plastic base, gelatin and emulsion. And when you talk about an X-ray packet, it is this packet which has a plastic cover, the lead shield, the black paper and the plastic film. Please don't confuse between the two because if you are going to tell me about the X-ray film, then I'm asking for the packet. And if you're going to write about the X-ray packet when I'm asking about the X-ray film, you'll get 0. So be careful, read your paper properly. If it's X-ray film, then you talk about the plastic base, the gelatin and the silver crystals, the crystals which are there, the silver halide crystals. When I ask you for the packet, you talk about the plastic cover which protects it from any contamination and moisture, the lead foil which prevents backscatter radiation and gives strength and backing, the black paper which prevents, the black paper which prevents any light leakage, and that's it, and the film which helps you to record the image. Now, the Bitewing radiography, this is used to detect intraproximal caries, monitoring progression of entry caries, detect secondary caries, evaluate periodontal conditions. And it is mostly used in the posterior region for the premolars and the molar area. You have a film which has a Bitewing tag, or you have a Bitewing film holder. Patient bites on the tag and the central ray is directed at 10 degrees, plus 10 degrees. Okay? Anterior Bitewing ellipses are also taken, but not very, very routinely. Occlusal radiography or sandwich radiography. Now this is taken to locate retained tools of extracted teeth, supernumerary teeth, foreign bodies, salivary stones, and meaning especially for expansion of the lesion. Now, the occlusal films, occlusal radiography is classified into maxillary occlusal and mandibular occlusal. It is further classified into cross-sectional and topographic views. Let's see. Now see, all these are occlusal views. The upper ones are the maxillary, the lower ones are the mandibular. Now you can see that this is different from this. Now this is a cross-sectional view with the point of entry is from the bridge of the nose. Whereas this is the topographic view, anterior topographic view, where the point of entry is from the tip of the nose. This was the bridge of the nose, this is the tip of the nose. And this is on the lateral side, So this is topographic anterior, this is topographic lateral. Left or right, you have to mention as per the directions. Same way you see is this is occlusal of the mandibular occlusal views. This is cross-sectional. Point of entry is about 3 centimeters behind the chin. This is the topographic mandible anterior, where the point of entry is at the chin, and this is the lateral topographic. Okay? So now this is the difference between inner spotters. If you tell me that this is a maxillary occlusal view, I will give you half the marks. But if you tell me whether this is a cross-sectional or a topographic view, I know that you know more and you understand more, and so I will give you half a mark more. Intraoral localization technique, there's one very useful technique known as the tube shift or Clark's rule or slob rule. Slob is S-L-O-B, that is same side lingual, opposite side buccal. Very simple. Now this is a periapical radiograph which is taken, and this is an impacted molar. Now in case I want to know whether it is placed buccally or is it placed lingually. Now what I will do is take another radiograph. I'm not getting it. Take another radiograph and shift the tube mesially. Now, if the tooth also shifts mesially, then same side mesial. If the tooth shifts lingually, then it is in the opposite side direction. So now here you can see it has shifted. Radiograph is taken with the mesial shift and the molar appears to have shifted mesially. So it is on the same side. So this is lingually placed. So this is a helpful guide to the surgeon. Now, it is important to know that we are talking about conventional imaging, but the world is progressing and digital imaging is coming into it. So we also need to be aware about what is digital imaging. The advantage of digital imaging is we do away with the darkroom processing, no chemical processing, no radiographic film. Instantly we'll be able to see the image, less radiation to the patient. Per cost of exposure, the cost is very, very less. Ability to manipulate, because you see it on the computer, and in computer you have lots of tools, so you can enlarge, you can, if the contrast is not proper, or the density is not proper, you can make it lighter, darker, etc. And you can play with the tools which are available. You can measure certain things, okay? And these images can be easily transferred by email, via WhatsApp. So if you want a second opinion, then it can be easily taken. Disadvantage, the initial setup cost is very expensive. Not only do you have to buy the equipment, you also have to buy a laptop you need, okay? So the initial cost is more expensive. Image quality is not as good as your conventional films. Sensors are bulky and difficult to put in the patient's mouth. You need a computer network, lack of hard copy. Panoramic and cephalometric units are very, very expensive. Acceptance by third-party carriers is variable. Okay. Now, if you want to the storage, digital is easier. Distribution, digital is easier. Viewing, again, soft copy can be easily viewed and by a large number of audience. Lifespan, the screen film deteriorates over a period of time, whereas this image remains as is. Cost, analog is cheaper per film, but in the long run, the digital becomes cheaper. These are the various sensors. This is the film. This is the PSP sensor. This is the RBG sensor. And this is this has wires. These are connected. And already in dentistry, we have a lot of tubings and wires all across our floor. This is an additional wire. And in case you're working stool or something, or you step on this wire, that's the end of it. You have to buy a new sensor. So because of that also, these new sensors are there with a small little battery so that these wires are eliminated. But this makes the sensor more large and bulky, and it is more difficult for the patient to put in the mouth. So every advantage has a disadvantage. You need to find out what is most comfortable for you to work with. This is just a picture. This is a OPG which is showing you a digital OPG and a conventional OPG. Now if my digital OPG had also come something like this, with the tools which are available, I could have manipulated and seen. But once a conventional radiograph is processed and developed, I cannot make any changes. Only thing is I can use the intensifying light, so that I can increase the light or decrease the light and maybe get a better visualization. Effects of radiation on biological tissues. Now, like this, I already told you, it is because of the property of ionization that various biological changes take place. The radiation effects can be classified as deterministic and stochastic, which can be either direct or indirect, acute or chronic. You can go up to the biological molecules where protein and nucleic acid is affected, cellular levels where intracellular and cell kinetics are affected. And coming to acute and chronic, I have already mentioned that you have somatic changes and genetic changes. Somatic changes are changes which are seen during the lifetime, and it also can cause shortening of the lifespan. Whereas genetic changes are the ones which will be seen in the offspring. Okay? An injury during lifespan again can be acute and immediately seen, or there can be late chronic exposure, and the changes will be gradually taking place. Now, general effects of radiation on the oral cavity, the oral mucous membrane is affected, the taste buds are affected, the salivary glands are affected, and because the salivary glands are affected, the consistency of the saliva and the content of the saliva changes, and this is what brings about changes, and the tooth radiation carries. Otherwise, an adult tooth is resistant to the direct effect of radiation. An adult tooth will not get affected by radiation. It is only because the saliva is affected, and the tooth is surrounded by saliva all the time, and then hence you have this radiation caries, which are of three types: primary involving cementum and dentine, generalized superficial lesions, and dark pigmentations. Now let me tell you, these effects of radiation that we are talking about now, this is not during your day-to-day dental diagnostic radiographs. Now these effects, radiation effects, are most commonly seen in people who are taking therapeutic radiation. So we need to keep this in mind. Okay? Sources of radiation in a dental department. You have primary radiation, that is directly from the X-ray tube. Okay? Then you have scattered radiation, which comes from other parts of the X-ray tube, not from the PID. And then you have stray radiation. I made a mistake. Primary radiation is what comes out of the PID. Scattered radiation is what comes out from the objects which are irradiated from the objects. And stray radiation or leakage radiation is what comes out from the X-ray tube other than the PID. So now what do we need? How do we protect ourselves? We need protection for the operator, protection for the patient, and protection for the environment. Protection from radiation for the operator. Like I told you, leakage radiation is through the tube head housing, and scattered radiation is from objects other than the patient. So now how do we protect ourselves? One is position distance rule. We need to stand 6 feet away from the source of radiation, stand behind a barrier. If there is no shield, use a lead apron. The film should never be held by the operator. Do not use fluorescent mirrors in the oral cavity while taking radiographs. Avoid holding the tube head. Neither tube housing nor cone should be held by the operator dentist. The machine should be periodically checked up. Use of high-speed films. Replace short The plastic cone which is commonly available in the machines should be replaced by an open-ended lead-line cone. Adequate filtration, use of collimator, use of the TLD badge to monitor how much radiation you are exposed to. These are happy little lead aprons which the operator doesn't use, but the children who are being radiographed, they are covered by this. This is the TLD badge with which you can monitor the amount of radiation you are exposed to. Protection for the patient. First of all, the requirement for the need to take a radiograph should be determined. When do you take a radiograph? If your clinical diagnosis will change or the treatment methodology will change after taking a radiograph. This is the same rule which you apply instead of taking a conventional IOPA and you refer a CBC. You need to know the importance and whether it's going to help you in further diagnosis and the treatment of the patient is changed. So selection of the image receptor, that is the type of film you use, fast films or slow films, film screens, intensifying screens, whether you want to use digital radiography or conventional radiography, focus spot distance, collimation of the beam, filtration of the beam. Now, the KVP of the machine which you are using, there are some very, very cheap machines available in the market. Another KVP and MA which is there is less. Now, these machines will not give you a good radiograph of good diagnostic value. They are cheaper, but the diagnostic value is less and they will last for a lesser time also. So, you need to know which machine to buy, and the KVP and MA is one of the criteria for selection. Use of open-ended cylinders, use of film holding devices, use of timers. Previously, we used to get conventional timers, spring control timers, and the timing for exposure was in minutes. Now we have 0.5 seconds. Okay, those are the electronic timers. Positioning of indicating devices, use of protective barriers, use of a proper technique, processing of the image should be proper and interpretation. Taking a radiograph is not enough. If the technique that you have used is not proper, you will not get a good image. If you don't process it properly, you will not get a good image. And after doing all this, if you don't know the interpretation and you are not able to interpret properly, the entire exercise is wasted. Now, protection from radiation, protection from the environment. Basically what we do is there are certain quality assurance tests which need to be carried out. And you have to make sure that the primary beam should always be directed towards the patient and the area to be radiographed. Patient should be positioned so the X-ray beam is aimed at the wall of a room and not to a door so that the radiation doesn't go to the next room. There are certain criteria given by AERB of the thickness of the wall, whether it should be lead line, and the thickness of the bricks which have to be used, which you need to look up before you start your clinic. Okay, so these are very important. Continuing dental education for the operator, for the patient, radiation monitoring devices, and like your TLD badge, and also the environment where then regular quality control checks are done by AERB and Dentech to find out whether there is any stray or leakage radiation happening from your machine.